Welcome to this lecture. Welcome to this lecture dedicated to glioblastoma given by Here are our disclosures. Glioblastoma is the most common primary brain cancer. Secondary brain tumors or brain metastases are more common. Glioblastoma accounts for 15% of primary brain tumor, 50% of malignant primary brain tumor, 60% of gliomas. The incidence rate of glioblastoma is 3.5 new cases per 100,000 population per year. Approximately 12,500 new cases are diagnosed each year in the US. The sex ratio, male out of female, is 1.6, and the median age at diagnosis is 65 years, with an incidence rate increasing with age. At the diagnosis, the majority of GBM patients are in good clinical condition with a Karnofsky Performance Status (KPS) score above or equaling 70%, meaning that patients are able to take care of themselves at home but unable to work. In contrast, approximately a third of GBM patients need help for daily activities. A detailed KPS scale is reported in the next slide. The most common neurological signs revealing the disease is headaches or increased intracranial pressure syndrome, combining severe headaches, nausea, vomiting, and/or diplopia, commonly known as double vision. Patients can also present a focal neurological deficit such as motor deficit, sensitive deficit, and/or dizziness. Cognitive impairment, known as decline in cognitive abilities such as memory and thinking skills, is also a frequent symptom detected at diagnosis in 50% of GBM patients with memory and/or speech troubles, for example. Finally, partial or generalized seizure is the first symptom of the disease in 50% of GBM patients. Here you can see a detailed Karnofsky Performance Score (KPS) scale. The KPS is one of the major prognostic factors in GBM patients, regardless of the other well-known prognostic factors, for example, age, MGMT promoter methylation. The critical threshold is 70%. In the presence of neurological clinical signs suggestive of a brain pathology, particularly a brain tumors, the gold standard examination is brain MRI with and without contrast agent infusion. Usually, glioblastoma appears as unique mass, hypointense on T1 weighted images, with heterogeneous contrast enhancement after gadolinium infusion, and hyperintense on T2 weighted images. Here you can see two examples, a left frontal lobe glioblastoma on the top and the right temporal lobe glioblastoma on the bottom. Advanced imaging technologies such as amino acid positron emission tomography (PET) scans may be useful in challenging diagnostic cases. For instance, the left frontal lobe tumor depicted in the left image shows no contrast enhancement, which suggests a low-grade glioma. However, the dopamine PET scan on the right reveals high metabolism, indicating a high-grade glioma. After a tumor biopsy, the pathological examination confirmed the presence of a glioblastoma. The World Health Organization, the WHO, published a new brain tumor classification in 2021. To make a definitive diagnosis of glioblastoma, a tumor must meet several histomolecular diagnostic criteria, including a diffuse or infiltrative proliferation of gliomatous cells that is not circumscribed, with predominant astrocytic differentiation, with no IDH or histone H3 mutation, and with at least one of the following criteria: microvascular proliferation as indicated by the red star in the picture, necrosis as indicated by the green star in the picture, third promoter mutation, EGFR gene amplification, and or chromosome 7 gain and chromosome 10 loss. The standard of care for glioblastoma patients with good functional status involves maximal safe surgery unless surgery is contraindicated. Otherwise, the surgical procedure is limited to a diagnostic biopsy. This is followed by concurrent radiotherapy and temozolomide chemotherapy. The radiation dose is shorter and lower for elderly patients to reduce the risk of early and long-term neurotoxicities. The third step of treatments involves adjuvant temozolomide for 5 days per month for 6 months, which may be longer for elderly patients. For patients in good clinical conditions after radiotherapy, electrotherapy that delivers tumor-treating fields has been shown to increase progression-free and overall survival in this subgroup of glioblastoma patients. The STUP clinical trial, conducted in 2005 and updated in 2009, established the standard of care for young patients below the age of 70 and in good clinical condition, I mean with a KPS score above 70%. By comparing the two Kaplan-Meier survival curves presented, we can observe that the addition of temozolomide to radiotherapy, as per the STUP protocol, led to a significant improvement in both progression-free survival and overall survival when compared to radiotherapy alone. The blue curves represent the combined treatment, while the red curves represent radiotherapy alone. The median overall survival increased from 12.1 months in the radiotherapy arm to 14.6 months in the radiotherapy plus temozolomide arm. When it comes to delivering radiotherapy, certain criteria should be respected. Linear accelerators with an energy level of 6 MV or more and dedicated computed tomography, CT, and three-dimensional planning system should be used. The treatment should be focal and conformal with a volume of gross tumor volume plus a 2 to 3 centimeters margin for the clinical target volume. The dose of 2 grays per fraction should be administered once daily, 5 days per week, over a period of 6 weeks for a total of 60 grays. Despite the benefits of radiotherapy, it can have side effects. The most common ones include fatigue, hair loss, encephalopathy, and radionecrosis. It's important to manage its side effects appropriately to minimize the impact on the quality of life of the patients. By adhering to the recommended criteria and managing side effects, radiotherapy can be as safe as possible and effective treatment for patients with glioblastoma. Temozolomide is an alkylating cytotoxic agent that is commonly used in the treatment of glioblastoma. While it is usually administered orally, an intravenous formulation is also available if necessary. However, oral administration is preferred as it is more convenient and can be done at home. Like many other chemotherapeutic agents, temozolomide can have side effects. The most common ones are hematological toxicities such as thrombocytopenia and neutropenia, which can lead to an increased risk of infection. It's important for patients receiving temozolomide to be monitored closely for these side effects and to receive appropriate treatments if necessary. Despite these potential side effects, temozolomide remains an effective treatment in glioblastoma. For newly diagnosed patients with MGMT methylated glioblastoma who are in good clinical condition with a KPS score of 70% or higher and are aged below 70 years, an alternative standard of care treatment is the combination of the standard of care plus lomustine, which is another alkylating agent. This treatment option has been shown to be effective in a phase 3 randomized clinical trial conducted by Erdinger and collaborator in 2019. With this alternative therapeutic regimen, although there was no increase in progression-free survival, the median overall survival was increased in the intensive chemotherapy arm. Specifically, the median overall survival was 46.9 months in the group receiving temozolomide plus lomustine compared to 30.4 months in the group receiving temozolomide alone. This is a randomized, controlled phase 3 clinical trial that established the standard of care treatment for elderly patients aged 65 years or above who were newly diagnosed with glioblastoma and had a good performance status. The treatment regimen was a modified version of the Stupp regimen as presented earlier. The trial was published in 2017. The modified version of the Stupp protocol involves maximal safe surgery or biopsy followed by a radiotherapy regimen of 40 grays along with concurrent temozolomide and 12 cycles of adjuvant temozolomide. This treatment has shown an increase in median overall survival from 7.6 months to 9.3 months. This is the randomized phase 3 clinical trial that demonstrated the benefits of adding tumor treating fields to the standard of care for glioblastoma patients in good functional status after the concurrent radiochemotherapy part of the Stupp protocol. Tumor treating fields, or TTF, are a novel cancer treatment modality that involves the use of low-intensity, intermediate-frequency alternating electric fields. These fields are generated by a battery and are delivered to the brain through a transducer array that is placed on a shaved scalp, as illustrated on the bottom right of these slides. TTF disrupts the cell division of proliferating cancer cells. It is recommended that TTF be delivered for at least 12 hours a day to maximize their therapeutic effects. One of the most common side effects of TTF is skin irritation, which can be managed with proper skin care. The mechanism by which tumor treating field disrupts cell division in proliferating cancer cells involves two major pathways. The first pathway involves the disruption of microtubule polymerization and depolymerization by targeting tubulin, a protein involved in cell division. This results in the formation of abnormal mitotic spindles, which leads to the arrest of cell division and ultimately cell death. The second pathway involves the disruption of the formation of septin filaments, which are essential for cytokinesis, the final stage of cell division. By interfering with the formation of septin filaments, TTF prevents the completion of cytokinesis and the formation of two daughter cells. This ultimately leads to cell death and the inhibition of tumor growth. As you can see in these two Kaplan-Meier curves, tumor treating fields increase significantly progression-free survival and overall survival in newly diagnosed glioblastoma patients who completed the concurrent radiochemotherapy part of the standard of care in good clinical conditions. First recurrence glioblastoma is a challenging clinical scenario for which there is currently no validated standard of care. However, a second surgery is often recommended when there is an expectation of clinical benefit followed by medical treatment. Several medical options are available for treating first recurrence glioblastoma, including re-irradiation and second-line chemotherapy, including lomustine or lomustine plus bevacizumab. Lomustine is an alkylating agent presented earlier. It has shown some efficacy in the treatment of recurrent glioblastoma and is often used as a single agent or in combination with other treatments. Bevacizumab is a monoclonal antibody. It targets vascular endothelial growth factor A, and it has shown some efficacy in the treatment of recurrent glioblastoma. Re-irradiation is another treatment option that can be considered in selected cases, particularly when the recurrent tumor is localized. However, re-irradiation is associated with significant toxicity, and careful patient selection is important. Overall, the treatment of first recurrence glioblastoma requires a personalized approach that takes into account the patient's clinical status, the location and extent of the recurrent tumor, and the available treatment options. The addition of bevacizumab to lomustine has been evaluated in this randomized controlled phase 3 clinical trial for the treatment of recurrent glioblastoma patients. The trial demonstrated a clinical benefit of this combination therapy compared to lomustine alone. As discussed in a previous slide, bevacizumab is a humanized monoclonal antibody that targets vascular endothelial growth factor A, VEGF-A. The clinical trial presented in the previous slide showed that the combination bevacizumab plus lomustine results in a longer progression-free survival, PFS, compared to lomustine alone. Indeed, the median PFS is 4.2 months in the experimental arm testing the combination versus 1.5 months in the control arm with lomustine alone. It is worth noting that the difference in overall survival between the two groups was not statistically significant. The therapeutic combination of bevacizumab plus lomustine can be associated with several side effects, some of which can be serious. One of the most common side effects of bevacizumab is high blood pressure, hypertension, which can be managed with medication. However, another common and serious side effect of bevacizumab is an increased risk of blood clots, particularly venous blood clots. Lomustine can also cause several side effects, including hematological toxic effects such as a decrease in the number of blood cells. When bevacizumab and lomustine are used together, the side effects can be combined and potentially more severe. There are several innovative treatments that are currently being investigated or under investigations for the treatment of glioblastoma patients. These include molecular targeted drugs, immunotherapies, antibody-drug conjugates, classical cytotoxic chemotherapies, medical devices, and repurposed drugs. There are various molecular targeted therapies that have been developed and are presently being explored for treating glioblastoma. These therapies are specifically designed to target particular molecules or pathways that are involved in the growth and advancement of cancer cells. A number of these molecular targeted therapies have demonstrated encouraging results in subgroups of diffuse gliomas, including glioblastoma. For example, BRAF or NTRK inhibitors have exhibited promise in preclinical and clinical studies. Conjugated antibodies are a type of cancer therapy that uses antibodies to target specific molecules or receptors on cancer cells. These antibodies are modified to carry or conjugate with other therapeutic agents such as chemotherapy drugs, radioactive particles, or other immune system modulators. The conjugated antibodies work by binding to the specific molecules or receptors on the surface of cancer cells. This binding allows for the delivery of the therapeutic agents directly to the cancer cells, increasing the concentration and the efficacy of the drug in the tumor while reducing exposures to healthy tissues. Advanced clinical trials were conducted to evaluate the effectiveness of an anti-EGFR antibody conjugated with auristatin, a chemotherapy agent, in treating glioblastoma. Despite promising preclinical data supporting this therapy, the clinical trial yielded negative results with no significant improvement observed in glioblastoma patients. Immunotherapies have significantly improved the prognosis of multiple cancers, including melanoma. The most advanced immunotherapies currently being evaluated for glioblastoma are PD-1 inhibitors. Indeed, two randomized phase 3 clinical trials, the CheckMate 498 and CheckMate 548 trials, have evaluated the effectiveness of PD-1 inhibitors in newly diagnosed glioblastoma patients. The CheckMate 498 trial included 560 patients with MGMT unmethylated glioblastoma, while the CheckMate 548 trial enrolled 716 patients with MGMT methylated glioblastoma. The primary objective of these trials was to assess whether adding a PD-1 inhibitors to standard therapy could improve overall survival in these patients. However, the results of both clinical trials indicated that PD-1 inhibitors was not associated with any clinical benefit in terms of overall survival. In other words, the addition of the PD-1 inhibitors did not improve the survival outcome of glioblastoma patients compared to the standard therapy alone. The findings of the CheckMate 498 and CheckMate 548 trials are disappointing, given that PD-1 inhibitors have shown promising results in treating other types of cancers. However, a better understanding of the mechanisms of resistance to immunotherapies in glioblastoma could pave the way for the development of new immunotherapeutic strategies. The MGMT promoter methylation is a unique and validated molecular biomarker in the management of glioblastoma patients. Multiple clinical trials have confirmed that MGMT promoter methylation status is closely associated with both patient outcome and response to chemotherapy agent temozolomide. When MGMT promoter is methylated, the expression of the MGMT enzyme is inhibited. As a result, the DNA damages induced by temozolomide in tumor cells cannot be repaired, ultimately leading to cell death. As seen, the prognosis of newly diagnosed glioblastoma patients greatly depends on several factors, including the MGMT promoter methylation status, the patient's age, and the patient's clinical condition. In patients with good clinical conditions and an MGMT unmethylated tumor, the median overall survival is around 14.9 months versus 32.1 months in patients with an MGMT methylated tumor. To be comprehensive, in the overall population of newly diagnosed glioblastoma patients, the median overall survival is approximately 8 months. Thank you very much for your attention, and I take the opportunity of these last slides to thank both the EURACAN and GlioResolve consortia.